We now begin with our next section, which is based on antepartum fetal surveillance by way of ultrasound biophysical profile and ultrasound umbilical artery Doppler assessment and its role in managing pregnancies complicated by fetal growth restriction. The first question is, which is not a part of the biophysical profile? So this is quite a direct question. It requires you to know the components of an ultrasound biophysical profile. The choices are fetal respiratory movement, fetal movements, contraction stress test and NST. The correct answer here is contraction stress test. Contraction stress test is not a part of an ultrasound biophysical profile. So what is biophysical profile? It is a method of antepartum fetal surveillance performed as a scored test over 30 minutes. It involves ultrasound assessment of 4 important parameters of fetal behavior, that is fetal gross body movements, fetal breathing, fetal tone and amniotic fluid volume. Now each of these parameters, if satisfactory, is given a score of 2 and if unsatisfactory is given a score of 0. Added to this is the performance of a non-stress test. If a non-stress test is reactive, then the score is 2 and if it is not reactive, then it is 0. So the maximum score for a biophysical profile is 10 with an NST and 8 without an NST. What is modified biophysical profile? Is it the combination of NST with fetal tone with amniotic fluid index, NST with AFI or amniotic fluid index, NST plus fetal tone plus AFI? Here the correct answer is NST and AFI. So modified biophysical score is an abbreviated form of a biophysical score in which we are assessing 2 components. One is the non-stress test, whether it is reactive or non-reactive, and amniotic fluid volume as measured in terms of the amniotic fluid index. Now the biophysical profile, the modified biophysical profile, it takes much lesser time to perform than the conventional 30 minutes biophysical profile and is quite informative about fetal condition. Now here I just want to emphasize that when we measure the amniotic fluid volume can be measured in 2 ways. One is by measuring the single deepest pocket of amniotic fluid in the uterine cavity, also referred to as the maximum vertical pocket. The normal value of a single deepest pocket of amniotic fluid is between 2 to 8 centimeters and less than 2 is regarded as severe oligohydramnios. Amniotic fluid volume can also be measured in terms of the amniotic fluid index. For the amniotic fluid index, the uterine cavity is divided into 4 quadrants and the depth of the deepest pocket of amniotic fluid in each quadrant is measured and these are then added up to give us the amniotic fluid index. Now the normal value of amniotic fluid index is between 5 to 25 centimeters. Less than 5 is regarded as severe oligohydramnios. So when we are doing the biophysical profile, we represent the amniotic fluid volume or measure the amniotic fluid volume in terms of the single deepest pocket or the maximum vertical pocket, which if less than 2 centimeters is given a score of 0. In the modified biophysical profile, we measure the amniotic fluid volume in terms of the amniotic fluid index. Now let us start with another very important topic, and that is umbilical artery Doppler ultrasound and its role in management of pregnancies complicated by small for gestational age fetus or intrauterine growth restriction. So Doppler ultrasound, as we all know, is a technology by which we can study the blood flow dynamics in various vessels of the body, and just like all other branches of medicine, Doppler ultrasound has acquired very important specific roles in obstetrics as well. For example, in obstetrics, the measurement of uterine artery Doppler flows in a pregnant woman are used as indicators for development of preeclampsia or severe preeclampsia. The blood flow through the fetal middle cerebral artery can be assessed by Doppler and the middle cerebral artery peak systolic velocity in the fetal middle cerebral artery can be measured, and this is used for monitoring fetuses in pregnancies affected by Rh negative isoimmunizations, and MCA PSV can serve as indicators of fetal anemia and a guide to intrauterine transfusion. The third and the most important is the role of umbilical artery Doppler in management of pregnancies complicated by fetal growth restriction. Questions have been asked on this, and this is what we are going to study about. Now, let us talk about the normal physiology of maternal uteroplacental circulation. Now, in normal pregnancy, as pregnancy advances, the uteroplacental resistance to blood flow progressively decreases. So, in pregnancy, there is a continuous forward flow of blood through the umbilical artery from the maternal side to the fetal side, and as the pregnancy progresses, this blood flow, particularly the blood flow to the baby during maternal diastole, progressively increases. In pregnancies complicated by intrauterine growth restriction, the underlying etiology could be maternal complications, medical complications, most commonly hypertension or preeclampsia, maternal diabetes, antiphospholipid antibody syndrome. So whatever the etiology, the basic underlying pathophysiology is that there is increased resistance of the uteroplacental circulation to blood flow, which results in a decrease in the blood flow to the fetus, particularly during diastole. So, in the initial stages, the diastolic blood flow to the fetus decreases, that is blood flow to the fetus during maternal diastole. Now, if this pathophysiology intensifies, then we may reach a time when the blood flow to the baby during diastole actually stops, which is called absent end diastolic flow. Or if the resistance increases further, then the blood flow reverses, that is, it starts flowing in the opposite direction from the fetal to the maternal side during diastole, which is called reversed end diastolic flow. Now, let us try to understand this with the help of the umbilical artery Doppler waveforms. Now, this is a normal umbilical artery Doppler waveform, continuous forward flow in the umbilical artery from the mother to the baby, both during systole as well as during diastole. Now, this represents the blood flow to the fetus during maternal systole, and this represents the blood flow to the fetus during maternal diastole. So, this is a normal umbilical artery Doppler waveform. Now, as intrauterine growth restrictions start setting in because of increased uteroplacental resistance, the diastolic blood flow decreases. So, we can see here the systolic blood flow remains relatively unchanged, but compared to the normal, the diastolic blood flow has decreased. As the process intensifies, the diastolic blood flow to the baby may actually stop, and this is what is called absent end diastolic flow. So, this particular waveform represents absent end diastolic flow. So, we can see these gaps. Here, there is no blood flowing to the fetus. These are the diastolic gaps when there is no blood flowing to the fetus. And there can be a time when the direction of blood flow actually reverses. That is, the blood flow starts flowing in the reverse direction as is happening here. And this is what is reversed end diastolic flow. So, decreased diastolic flow, absent reversed end diastolic flow represents a continuum of increasing pathophysiology of the uteroplacental circulation. So, how do we use umbilical artery Doppler assessment in managing pregnancies complicated by fetal growth restriction? So, fetal growth restriction is defined when the ultrasound estimated fetal weight is less than the 10th percentile for that gestational age. So, in simpler words, fetal growth restriction means that the fetus is not adequately grown for its gestational age, and when this is less than the 10th percentile for the gestational age, it is defined as fetal growth restriction. So, as of now, we don't have any effective intervention available for fetal growth restriction. No treatment which can reverse the fetal growth restriction or make the baby grow better once the pathophysiology has started. The only effective intervention is delivery, and the most important thing in the management of these pregnancies is to monitor the fetus while it is in utero and accordingly appropriately timing the delivery. Now, the timing of delivery, the appropriate timing of delivery is what is difficult, because if we deliver these fetuses too early, then we face significant complications related to prematurity, which could be respiratory distress syndrome, intraventricular hemorrhage, necrotizing enterocolitis, prolonged NICU stay, and also definitely significantly increased cost of treatment. On the other hand, if we prolong the intrauterine stay of the fetus so that it gains maturity, we incur the risk of stillbirth or intrauterine death. So, how do we time the delivery? The timing of delivery is guided by umbilical artery Doppler assessment of fetus in utero. Let us see how. So, in a pregnancy complicated by a small for gestational age fetus or intrauterine growth restrictions, once a diagnosis is established, we monitor the pregnancy by 2 weekly ultrasounds for fetal growth, fetal Leica volume, and umbilical artery Doppler assessment. So, at any time, if the umbilical artery Doppler becomes abnormal, that is the diastolic blood flow to the baby decreases, then we need to intensify our surveillance a little bit more. And so, if the umbilical artery Doppler becomes abnormal, then we perform twice weekly assessment of umbilical artery Doppler of the fetus and continue this way. If at any time absent or reversed end diastolic flow develops. Now, absent or reversed end diastolic flow are ominous signs and are potential indicators of intrauterine death or stillbirth. So, if there is absent or reversed end diastolic flow represented as AREDF on umbilical artery Doppler, then further management depends upon the gestational age of the fetus. If the fetus is more than 34 weeks, then we can consider delivery of the fetus, because at 34 weeks complications of prematurity are not very significant. But if the fetus is less than 34, in particular less than 32 weeks of gestation, then if we hastily deliver the fetus, then we incur all the complications of prematurity. Plus, for taking care of a less than 32 weeks premature fetus, very good NICU facilities are required, which may not always be available. So, the aim of pregnancy when there is absent reversed end diastolic flow with a fetal maturity of less than 32 to 34 weeks is to intensify the surveillance, admit the patient and do a daily assessment of the umbilical artery Doppler, biophysical profile and NST to inform us about the fetal well-being. So, this is continued till the time either the fetus reaches a reasonable maturity, that would be 34 weeks, then you can deliver the fetus, or at any time if the Doppler flow through the fetal ductus venosus becomes abnormal. So, ductus venosus is a vessel which is present in the fetal circulation. We do not need to go into details of this. All we need to know is absent reversed end diastolic flow in a significantly premature fetus. We deliver the baby at any time if the ductus venosus flow becomes abnormal, because that is indicative of fetal acidemia. So, what have we learned? We have learned that in a growth restricted fetus, monitoring is by way of umbilical artery Doppler assessment every 2 weeks. Once the diastolic blood flow decreases, umbilical artery Doppler becomes abnormal. We do a twice weekly umbilical artery Doppler assessment. If absent reversed end diastolic flow develop more than 34 weeks, consider delivery. If less than 32 to 34 weeks, then continue daily monitoring till the fetus reaches reasonable maturity, and then you can deliver the fetus, or if the ductus venosus flow becomes abnormal. Now, another important thing to remember here, which is a dictum followed in obstetrics, is that In any high-risk pregnancy, whenever you contemplate delivery of a baby preterm, that is less than 36 weeks of gestation, within the next 7 days, you need to consider giving the mother a course of antenatal corticosteroids. So, steroid administration to the mother, dexamethasone or betamethasone, helps in decreasing the complications of prematurity, in particular respiratory distress syndrome. So with this, let us tackle the questions related to umbilical artery Doppler assessment. Placenta grade 3, 35 plus 3 weeks of pregnancy, absent end diastolic flow in Doppler. What is the next management? So here placenta grade 3 is not very clinically significant. What is important is gestational age, which is more than 34 weeks, and there is absent end diastolic flow. What do you need to do? You need to consider delivering the fetus. And you will see if the mother has already received steroids within the last 7 days. If yes, you go ahead with delivery. If not, then you give her a course of steroids and time the delivery accordingly. So, dexamethasone and deliver the pregnant woman after 48 hours. Now, why 48 hours? Now, this is because the maximum effectiveness of a course of steroids is within 2 to 7 days of the initiation of the dose. From the time you give the first shot of dexamethasone, you ideally should wait for 48 hours to get the maximum benefit of the steroid. So here the answer is dexamethasone and deliver within after 48 hours. The next question, a 28 weeks pregnant lady presents with decreased fetal movements. On examination, the fundal height is 24 weeks, so obviously there is fetal growth restriction, and the umbilical artery Doppler study is given below. What should be the next step? So here important things are 28 weeks and an interpretation of the Doppler picture, which is showing no blood flow to the baby during diastole. So this is absent end diastolic flow, which is what is the crux of the question. You should be able to identify this. So we said this baby or fetus is extremely preterm. We are not going to rush into delivery because of the complications associated with severe prematurity. We are going to try and prolong the pregnancy 1 day at a time. So you admit the patient, give her steroid cover, because with absent reverse end diastolic flow, the balance may always tilt in favor of immediate delivery at any time. So you give steroid cover and monitor with daily Doppler and NST. That is the correct answer. Immediate termination of pregnancy, as I said, is not the right choice. Give steroids and take up for cesarean immediately is a similar choice, not right. Go for normal vaginal delivery. Now, in absent and reverse end diastolic flow, there is no role of giving a trial for normal delivery, because labor is going to accentuate the intrauterine fetal hypoxia, and if we subject this woman to normal labor, then we may have the birth of a severely acidotic compromised baby. So, absent reverse end diastolic flow, when we deliver, we have to deliver by elective cesarean section. A 30-year-old primary gravida is diagnosed with gestational hypertension and intrauterine growth restriction, presents at 34.3 weeks of pregnancy. Ultrasound reveals estimated fetal weight less than 3rd percentile and amniotic fluid index of 5 centimeters. Umbilical artery Doppler is as follows. So, can you identify the pattern of the umbilical artery waveform? So this is reversed end diastolic flow. So as you can see in diastole, the blood flow is reversed. So reversed end diastolic flow with 34.3 weeks, you give the patient steroids and you contemplate delivery. So here the answer is administer steroid and plan delivery. Drug of choice used for accelerating fetal lung maturity. So here we are talking about antenatal corticosteroids, which are to be considered when you contemplate that a high-risk pregnant lady may need delivery anytime between 24 to 36 weeks of gestation. The drugs that can be used are dexamethasone or betamethasone. So since these are very commonly used in obstetrics, you should be aware of the dosing of dexamethasone. Injection dexamethasone is given in a dose of 6 mg intramuscularly every 12 hourly for 4 doses. So The entire dose of Dexa takes around 48 hours, whereas injection beta-methasone is given in a dose of 12 milligram, 2 doses 24 hours apart. Again, intramuscular. So the use of antenatal corticosteroids has significantly reduced the morbidity and mortality related to prematurity by decreasing the complications such as respiratory distress syndrome, IVH and necrotizing enterocolitis. Now with this we come to the end of this session.